Thank you. So, as Andrew said, we've already done the A, the B, and the C assessment in trauma, and now let's focus on the D. So I want you to imagine you've got a trauma patient, you're doing your primary survey, and you've now got to the disability section. And just to say that we are focusing here on the assessment, we're not really going to be looking much at the treatment, although there are some things that are quite important as part of your primary survey. So my background is I'm a consultant in emergency medicine at University Hospital Coventry. I'm the major trauma lead for the West Midlands, and I have been a pre-hospital doctor for 25 years. So when I'm looking at the D assessment, I'm thinking of it as a pre-hospital clinician and also as a clinician receiving a patient in the emergency department. And that's actually really helpful because it means that I know the things that are really important to be done, but we're not going to avoid doing things. We're not going to get involved in doing things that aren't important. So we're going to be efficient, but we're going to do things that change the triage, the pre-alert and the handover of patients. So objectives of tonight is how are we going to assess disability in the primary survey for a trauma patient? I want you to consider some of the things that you've been taught before about the disability assessment, some of the textbook signs. And have you been taught actually correctly, or perhaps we need to modify how we present our patients? And then we're going to look at the signs of traumatic brain injury that we should be eliciting and the signs of spinal cord injury. And I always put a warning in to say that some of the things we're going to be talking about are very recent. So, for example, the NICE head injury guidelines were only published in May 2023. So some of the things we're talking about are very up to date. Your guidelines may not have caught up with that yet. And we all know that we must operate within our local policies and our local clinical guidelines. And the other thing is, if you're doing an exam and your examiner's got a checklist and they might be a bit old school, you just need to score the points on the checklist. So make sure that when you're sitting an exam, you're making your assessment as you'd expect them to be marking you. So here's what we're talking about. We've got to the disability section. What are the key features? And the thing that I've written at the bottom is that your A, B, and C findings are, of course, really relevant if we're thinking about traumatic brain injury or spinal cord injury. So has the patient got a patent airway? What's their respiratory rate and pattern? And what's their pulse doing? What's their blood pressure doing? Are all very relevant for both TBI and spinal cord injury. But the key things that we're going to talk about tonight are the inspection of the head and face to look for head injury. And remember that if someone's hit their face, that's also the front of their brain. So I think sometimes we focus on scalp injuries. Actually, a facial injury is a sign of a traumatic brain injury as well. We're going to look at Glasgow Coma Scale. We're going to look at pupil size and reactivity. We're going to talk about how we assess for spinal tenderness. We're going to talk about how we do a neurological assessment. So we're looking at the power and sensation of a patient's limbs. And of course, do not forget your blood sugar, because that is obviously a bit embarrassing if our patient's got a low GCS and we've missed the fact that they've got hypoglycemia. So let's start then with our external inspection. So there are obviously head injuries where there are blunt trauma or penetrating trauma, and you will notice that they have a boggy swelling, or they have a laceration, or they have bruising. And it is important that we elicit those signs as the clues on our primary survey. But there are also patients who can have a head injury without any external signs of injury. So you've got a picture there at the bottom. You've obviously got the blunt and penetrating where they would have evidence externally. But for example, if someone was exposed to a blast wave, which we fortunately don't see very often in the civilian setting, but that could be associated with a brain injury without any external signs. The one that's most common for us is bottom right. So I want you to imagine there's a young male involved in an RTC at high speed, and he goes from 80 miles an hour to 0 miles an hour. So, for example, the car hits a tree. And in that force, his body will move, but also the brain inside the skull will move. And the skull, the brain will hit the front of the skull as that movement occurs and get bruised. But also there are shearing forces that happen to the wiring, the electrical wiring in the brain, which will cause diffuse axonal injury. So if you went and saw that patient, there's no bang to the head, there's no sign of injury, but actually that brain has decelerated from a very high speed to 0, and those forces can give a patient a head injury as well. So just be aware of that. When we talked about the circulation assessment of the primary survey, you'll remember that I went on and on about making sure we've got hemorrhage control, and the scalp is a really good place to bleed from. We've all had that situation where you've moved the patient across on the scoop from the ambulance cot across to the ED trolley, and there's a massive pile of blood on the back on the sheet, and that's not cool at all. So as part of your C assessment, you should have looked for external hemorrhage and controlled any hemorrhage. If when you're doing your external inspection of the scalp and the face, you find bleeding, then obviously make sure that you sort that out before you move on. Now, this is a really common one. What's the definition of an open skull fracture or a depressed skull fracture? And the reason this is important is because for most of our major trauma triage tools in the pre-hospital setting, an open or depressed skull fracture will trigger on stage 2. And if you find that as an anatomical injury, you are often instructed to alert that patient into a major trauma centre. So what's an open skull fracture? That is if you look at a patient and they've got a big wound and you can see the skull and you can see a fracture. So it's not seeing the skull on its own, you have to see a fracture as well. Worst case scenario, an open skull fracture is where you see brain matter, which is clearly not a very good sign. And then a depressed skull fracture, so that's not a boggy swelling on the head. It's where you've got an obvious deformity, or you've got, when you feel the skull, you've got a palpable loss of congruity of the skull. So make sure that if you are looking at open or depressed skull fractures and you're diagnosing those, that you're using the correct descriptions for them, and you're not saying that someone's got an open skull fracture just because you can see the skull itself. And what you'd normally find is if somebody has got an open or depressed skull fracture, particularly depressed, then you would potentially notice that they would have a reduced Glasgow Coma scale. So these are obviously quite significant. The ones on the picture, these patients are not going to have a normal GCS. The other thing it's worth mentioning, we're about to start talking about Glasgow Coma scale and conscious levels, and this loss of consciousness. And we often ask patients, were you knocked out? And a lot of them say, oh, yes, I was. It's important for us to go into a bit more detail on that. So, okay, how long do you think you were knocked out for? And if they say seconds, well, that does not indicate a clinically significant injury. So seconds doesn't count. That probably represents someone being a bit dazed and disorientated. If we're talking minutes, and particularly if bystanders have witnessed someone to be knocked out, then that, of course, is more significant and we take it more seriously. But I often see on the notes, query LOC, let's try and see if we can get a bit more collateral history and get to the bottom of that, because it will really change what we do with the patient in hospital. So here's our Glasgow Coma scale. Of course, the GCS is actually only validated for traumatic brain injury, even though we use it in so many other conditions. And of course, when we measure it, we say eyes out of 4, verbal out of 5, motor out of 6. And if I tested you now, would you get all of those points right? Well, the point is, don't worry too much about that. But what I would say is if you are getting to the point where you need to give a GCS, so perhaps you're giving a pre-alert, perhaps you are handing over to the emergency department staff, or perhaps you're making a referral to the neurosurgeons, just take a minute and record it properly. So actually go to the patient, talk to them, do the painful stimulus and record a perfect GCS, because we want to know if there's going to be any deterioration or any improvement as we're moving along with time. You often get people who get flustered and they just make up a figure, and that isn't really very helpful when we're handing over clinical care. So take a moment, use an aid memoir and actually get a proper GCS. It only takes you a minute to do it, but having that accurate is actually really important. And I still use an aid memoir for some of it. So sometimes this is one of the things that catches us. So the eyes are dead easy, aren't they? We can remember those. And the verbal ones, they're a lot easier. But the motor, gosh, I always muddle this up. So obviously, if you obey command, you get a 6. And if you localize to pain, that's a 5. And if you withdraw to pain, that's a 4. But what about that one and that one? So a 3 is a decorticate position. And the way I remember this is the arms come up to the core. And then a 2 is a decerebrate position where the arms are sort of going out into extension. And then 1, of course, is no movement at all. So D cortica, arms to the core, gives you a 3. And of course, when we're doing a GCS, there's so many other things that can cause a reduction in conscious level. So has the patient been taking alcohol and drugs? And very often they have, and they also have a head injury. And then you say to yourself, well, I think it's just that they're drunk. The safest thing you can do is to assume the worst, and then you will not go wrong. So yes, they've probably got a GCS of 13 because they're drunk or they're on drugs, but actually they have banged their head, they have had a mechanism of injury. Let's treat them as if they are a head injury, and then we won't go wrong. Patients who are postictal, so particularly patients who have a fit, then they fall and bang their head, then they're postictal with a low GCS, and you're like, well, is it that they fell and had a head injury and then had a fit, or did they fit and then have a head injury? Again, really complicated, very difficult, treat worst case scenario. Hypoglycemia, I'm going to say it quite a lot. We must make sure that we do check a BM in patients with a low GCS, and then obviously treat if they have hypoglycemia. Patients with dementia. So what's the patient's normal GCS? Are they normally a 13 or 14? It is really worth, in those patients, taking some time to get a collateral history. And sometimes you're in a care home and nobody knows the patient, but can you actually ring a relative and find out, or, you know, can you ask somebody, one of their friends, are they normal for them? That is really going to change how you manage the patient, whether you convey them to hospital, because maybe you don't need to if they're fine, and also how we treat them in the A&E department, and whether or not we do a CT scan is really important, and it can obviously mean a big difference for the patient's management. And then finally, the reality of medical illness and head injury. So as an example, a patient who falls down the stairs who has urinary sepsis, and that's why they fell. And when they fell, they bang their head and they've got a GCS of 14. And they also have a temperature of 39. They also have a low blood pressure. They've fallen all the way down the stairs. It's all very confusing. So sometimes we do accept that we get patients alerted in as medical when they're trauma, and trauma when they're medical. But that is a reality of the medicine that we do. And we accept that, and that's absolutely fine. Think about worst case scenario. Could they have a traumatic brain injury? Follow that pathway and we won't go wrong. Just a reminder that there is, of course, a paediatric Glasgow Coma Scale. So you'll see in the third column are the grading system for children who are pre-verbal. So they can't obey commands and they can't obviously use words in the way that we would normally. There's no way that I remember this. I have to use an aid memoir so that I can record it accurately and keep checking it again. Lots of people say, well, why can't we just use AVPU? Well, yes, you can use AVPU, but it's not as accurate. You can't detect changes, whether it's an improvement or deterioration as well. And, you know, we can get this out and do it, and it doesn't take long at all. So where does Glasgow Coma Scale come in triage of pre-hospital patients? So all of you, whether you're in hospital or pre-hospital, be familiar with your local trauma triage tool. And for some of us, we work in regions where there are 2 ambulance services and we have 2 different tools, and they are often different. So this is West Midlands Ambulance Service. This is my biggest region. And you'll see that we have a tool developed from the MATS study from Sheffield. So it's based on data, and it's been validated on data as being more diagnostically accurate than the tool we had before. And you'll see on the first column that it says GCS motor score of 4 or less. So if people are withdrawing from pain or less, they would trigger to go direct to a major trauma centre following trauma. If you look at other regions, they sometimes use different scoring. So this is the one from the Scottish Ambulance Service, and their step 1 would be if you had a Glasgow Coma Scale of less than 14, so that's 13 or less. So have a look at your tool and remind yourself of where GCS would feature. And of course, when we were talking about open or depressed skull fracture, you'll see that's on the stage 2 of this tool, anatomy of injury. Now, really important to talk about Glasgow Coma Scale in the elderly. So the MRI scan on the left is of a young patient, and the MRI scan on the right is of an older adult with cerebral atrophy. And what you'll notice is that on the right, there's a significant larger area where there's no brain, there's just a space. So if the patient had a bleed on the brain on the left, that would fill very quickly any available space, and it would start to apply compression to the brain, and they would start to drop their GCS very quickly. The patient on the right, you'd fill with the same volume of blood, and it would make no difference to them whatsoever. There's no compression on the brain, there's no changes in the pressure. So what this tells us is there are patients who are older who have massive bleeds on the brain. You look at their CT scan, you're like, oh my gosh, and they're actually GCS 15, and that's why. So we have to be very careful with using Glasgow Coma Scale in the elderly. So they can look fine, they've still got a bleed on the brain, so make sure that you use your guidelines properly. The next thing we're going to talk about is pupils. So there's 3 things that we do when we check pupils. So what's the size of the pupil? And I have to get the side of the pen torch and look at the millimetre score on that, work it out. I am not very good at guessing. Are the pupils equal, and do they react to light? And so when we react to light, we shine a light in the eye, and in the direct reflex is that eye, the pupil constricts, and then obviously goes back to normal. And then sometimes people talk about consensual reflexes. You shine a light in one eye and the pupil constricts in the other eye. For the purposes of head injury, the direct reflex is the one that we're going to really be focusing on. So I'm going to talk about David Bowie, who was, unfortunately. So he was obviously a music artist, a performer, a actor in The Labyrinth. And for me, growing up in the 70s and 80s, a fantastic guy. And if you look at him, he's got different sized pupils. So the reason I'm showing you this is so you're going to remember this story. So when David was 15, he got into a fight with his friend who was also 15, and we think it was over a girl. And he was punched in the eye. And he had a number of eye operations on the eye on the left, but he remained with a larger pupil than normal. And actually for him, as an artist, it was quite cool having different sized eyes. And it also made him look as if he had different coloured eyes. So for him, it wasn't really a mega drama. But imagine if you went to David and he banged his head and he was talking to you, you'd go, oh my gosh, he's got unequal pupils, he's got a dilated pupil on the left, he's not reacting to light very well, he's got a head injury. Well, he hasn't, has he? Because he's had that eye injury in the past. So having a unilateral dilated pupil is not always because of head injury. So why do unequal pupils happen when you have got a head injury? Here's a nice diagram. So in this situation, the patient's had a subdural hematoma, had a bleed on the brain, and you can see it squashing the brain. So now with the pressure, the brain is looking for, oh, I need to get out of here. And there's a hole here, the tentorium, that you're getting uncal herniation. And when that's happening, it's squashing the oculomotor nerve, meaning that there is no longer sympathetic innervation. So the pupil can't constrict, it's just going to have unopposed dilatation. So on the same side as that bleed is, the pupil will be dilated. So in that patient, what do you think their GCS is going to be if they've got their brain herniating through a hole in their skull? It's not going to be 15, is it? So when you look at a person and they have a reduced conscious level and they have a dilated pupil, then yes, it could well be their head injury. But if their GCS 15, an unequal pupil, is not from a traumatic brain injury, it's impossible because look at the mechanism. So why might it be like that otherwise? Well, as we've already said, it can be congenital, you could be born with unequal pupils. And actually, 20% of the population have got a 1 millimetre difference between their pupils on each side. And you probably wouldn't know that. Previous eye surgery. So we see lots of older patients, don't we, with definitely they've got unequal pupils. Or like David Bowie, you'd had direct trauma to the eye. And that's quite common that we see that. So someone's had a head injury, the GCS 15, they've also probably been punched in the eye. And that's what the problem is. It's an ophthalmology problem, not a traumatic brain problem. I'm just looking on the desk. This is my son's squishy thing. And so just to emphasize the uncal herniation. There you go. Right. Coning. So the pressure in the brain is rising. We've got a bleed on the brain. We've had our uncal herniation. Our GCS is going to be reduced because clearly, look, our brain's herniating through our skull. Our GCS is definitely going to be reduced. We've also got the unilateral fixed dilated pupil because of the uncal herniation and compression of the oculomotor nerve. And then when that gets worse and we've got our midline shift, it's going to happen on the other side as well. And there's also now a degree of ischemia. So again, the pupils are not going to react because the blood supply has gone rubbish as well. And then as we get further down the brain and we're now herniating out through our brainstem, we're going to get bradycardia and we're going to have hypertension. So these are patients that we see, and they obviously have reduced GCS, they have the pupil changes, they also have bradycardia and hypertension. And then often, because the brain is dying, it will start to go bonkers, and they'll have runs of tachycardia, runs of bradycardia. It's all over the place. You don't know what's going on. These are obviously very sick patients. If we've got the ability to do so, we'd perform a pre-hospital emergency anaesthetic. We'd use secondary brain protection measures. We'd use temporizing drugs such as hypertonic saline. But to be honest, these patients just need to get going to the major trauma centre. And this is quite important. So this was a paper published by Mark Wilson quite a while ago now. And we're always kind of taught if you've got fixed dilated pupils, you're a goner. That's not actually the case. So these are patients who've had an extradural hemorrhage. And the reason that's important, the bleed's outside the brain. So whilst it's compressing the brain tissue itself is not damaged. So there is a chance of recovery if you can decompress. And these patients series of them who underwent decompressive surgery, you can see, yes, 1 in 3 of them died, but actually of those that survived, half of them had a very good neurological outcome. So when we see patients with bilateral fixed dilated pupils, if we can decompress them quickly, and that's normally with a craniectomy with neurosurgery, then they can actually do okay. Right, so we're going to move on with our examination. We've come off pupils now, and we're going to think about spinal examination. And in modern trauma care, we've moved away from log rolling patients. So in the past, we were obsessed with looking at the back for any missed injury. We palpated down the cervical, thoracic and lumbar spine. Now, though, if your patient's on the side, clearly have a good look at the back and do that palpation. But if they're already on their back, we're not going to move them to assess that. It is sometimes useful, though, to ask them if they've got any back pain and say top, middle or bottom to try and orientate where that is. And if they appear to be pain-free in their back, I sometimes ask them, can you just have a wiggle and just see if you've got any pain in your back, because that's going to be really important to hand over. So the next thing is assessing power and sensation, and this is universally done really badly. So how many of you said to a patient, grip my fingers and squeeze them? And they squeeze them, and that's your assessment of the arms. And you say, can you wiggle your toes? And that's your assessment of the legs. And unfortunately, a lot of us do that in the pre-hospital or the ED setting, and we miss some pretty spectacular injuries. So you need to work out, if you haven't already worked this out, how to do it in a really quick way. Look at some YouTube videos. So look up testing myotomes in the arms or the legs and make it a little project that you're going to improve on. So when I do it very quickly, I ask the patient to bring their arms up, don't let me push you down, pull me in towards you, push me away, cock your wrist back, don't let me move it, spread your fingers wide, don't let me squash them together, bring your thumbs up to the ceiling, don't let me push them down. That's the arms done, obviously, on both sides. With the legs, I'd start peripherally. So no one can straight leg raise when they've been laying flat on a scoop for ages. So start from the bottom. So start with the big toes. Can you bring your big toes up? Don't let me push them down. Can you cock your ankles back? Don't let me push them down. Point your toes to the floor. Bend your knee. Bring your heel into your bottom. Push me away. And then finally do your straight leg raise. And that's your myotomes done perfectly. And you will then identify if your patient has any significant weakness. The sensation bit is actually less important in the pre-hospital setting, but very important in the emergency department setting. And there you've obviously got a picture of your dermatomes. Really hard sometimes for people to remember which is which. And again, it's okay if you want to look and have a usual aid memoir, although perhaps not in front of the patient. So spinal cord injury can cause a number of symptoms and signs. So paralysis is obviously the most important one for us to be able to triage and diagnose a patient. Reduced sensation may also be present. Neurogenic shock, so that is where you have a loss of the sympathetic tone, so you have a bradycardia and a hypotension. Priapism, so you have a partial erection if you're a male patient. You notice that the patient's globally vasodilated, so they've got low blood pressure, but they look quite pink and their veins are easy to cannulate. That should make you think, actually, has this patient got neurogenic shock? And then if you've got a high spinal injury, so any injury above T6, you get the neurogenic shock. Any injury higher up in the cervical spine can affect your breathing because of your diaphragm. So the one to remember is C3, 4, 5 keeps your diaphragm alive. So if someone's got that funny breathing, it could well be because they have a high cervical spine injury. So if we work in hospital and you're assessing a patient who's got a spinal injury or potential spinal injury, then really when you're doing your motor, it's exactly the same. When you're doing your sensation, we need to go over it in a bit more detail. And these are Asia charts, which are really useful for reminding you where's where. As a sort of quick reminder, C4 is the top of your shoulder, T4 is the nipple line, T10 is the belly button. There's some of the quick landmarks. And then, of course, in hospital, we would have to do reflexes as well. Now, if there's one thing you can take away from this presentation, it's central cord syndrome. So give me a thumbs up if you've never heard of this before. So what the story is it's a patient, often they're elderly. They have fallen from standing and they've banged the front of their head. And that's caused a hyperextension injury. So you can imagine they've got a degenerative neck with loads of arthritis. The spinal canal that the cord goes in is really narrow, loads of osteophytes. They go like that and they pinch their spinal cord. The spinal cord gets bruised. And then, of course, you get neurology. So the older adult doesn't really complain of neck pain because often they haven't broken the neck. They just squash the spinal cord. They have really weak arms, so there's no power in their arms, but their legs are kind of all right. And it's not a universal weakness. So you test some of the myotomes and they're all right, and you test others and they're weak, but they're not right. But the thing about this is the arms are much weaker than the legs. And if you do the myotome examination that I just mentioned, you're going to pick that up. Lots of these patients come into the emergency department or move through to the medics, and we haven't had this proper assessment. And because it's not like a paralysis that you see normally from spinal cord injury, they get missed. But these patients should be treated like any other spinal cord injury. So if I was to see a patient with this in the pre-hospital setting, I would take them to a major trauma centre and I would pre-alert them, because this is a spinal cord injury, even though it's been caused by a known mechanism of injury and it comes across a bit weird. Had a patient last week who was alerted in as a fast positive, actually with this very, very, exactly the same sort of story. So just be aware of it and make sure that you don't miss it in the future. And I know now you're going to see when you go, oh my God. So where does triage come in for spinal injury? And actually, most of the triage tools are quite similar. So it's stage 2 on anatomy of injury. And most of the tools will say spinal injury with paralysis. We get a lot of patients who say that they've got pins and needles in their arms, or they've got pins and needles in their hands and feet. And sometimes that's from hyperventilating. But if it's just pins and needles and there's no motor deficit, that shouldn't change your triage. We're looking for paralysis if we're going to take someone to a major trauma centre. A lot of those patients with the vague pins and needles turn out not to have any significant spinal injury, and they can be looked after just as well in a trauma unit. Now, I don't want to obviously go off topic. We're talking about assessment, but while we're talking about spines, if you haven't already read this article about extricating patients from motor vehicle collisions, it's a nice bit of reading for you to do. So I'll just keep the slide up a bit longer so you can have a tag of the QR code. So essentially what this is about is we now know that the way to reduce movements of the spine is to get people to get out of a car themselves. It's not to spend hours cutting up cars. It's just to ask them to step out the vehicle. And when they can't get out the vehicle, the bottom line is we want to get people out as quickly as possible. We don't want to do fancy cutting. The role for cutting vehicles up is because people are physically trapped. They can't get out. So there's always going to be a role for the fire service, but really we need to move on very quickly, get these people out as soon as we can, and get their onward management started. So there's a bit of extra reading for you to do around the topic. And then, of course, the next thing that I've always gone on about, I think I've said it about 3 times, you won't forget it now, is when we're talking about disability assessment, make sure that you have recorded a blood sugar. I think actually paramedics are really good at this, and our triage nurses and ED are really good at this as well. So I said I wasn't going to talk about treatment, but just to really quickly mention that, as you can see, the main treatment of traumatic brain injury goes back to our ABC. That we're also going to talk about TXA. We also need to think about preventing impedance of venous return. So if you're going to put a collar on, don't put it on tight. If you're going to have a patient intubated, don't have the tube tie squashing their neck, and obviously have people in a head-up position. And making sure that we always remember to get patients to the right centre first time. So TXA, the CRASH 3 study was published in 2019, and that recommended if you had a patient with traumatic brain injury, a GCS of 12 or less, and they're within 3 hours of injury, they should receive 1 gram of tranexamic acid. And then in the NICE head injury guidelines, May 2023, they are recommending 2 grams. So we're giving 2 grams for head injury, 1 gram for the bleeding trauma patients. Your guidelines may not have caught up yet, but it's likely that this will be the way forward for patients with traumatic brain injury who meet those indications. This is just a reminder of how we treat patients to prevent secondary brain injury. Some of the things that I've already talked about, but obviously maintaining oxygen levels, CO2, blood pressure, glucose, temperature. You'll notice that our bodies love to be in the normal range. So wherever possible, keep the patient in the normal range. We've talked about how we treat raised intracranial pressure, so hyperosmolar therapy like hypertonic saline or mannitol, but actually often it's getting the patient to a major trauma centre where they can have neurosurgical intervention and decompression with craniectomy. Thinking about treating seizures. And then, of course, the really important thing, and this is where everyone can help, is treating coagulopathy. So if a patient's on an anticoagulant, it is really important for us to reverse that as early as possible in order to prevent deterioration. And for some of our older adults, they're not going to be suitable for neurosurgical or ITU intervention. So actually stopping the bleed getting worse could be, the only intervention that's going to make a difference for them. So when you're taking past medical history and drug history on a patient, it's really important that we identify if they are on any anticoagulants, and I've listed some of them there. The one that's not deemed to be quite so important for traumatic brain injury is aspirin monotherapy. So if you're on aspirin alone and nothing else, your risk of traumatic brain injury is probably not much greater than another person. If you are on aspirin and clopidogrel, you're in trouble. And any of the others on their own, obviously not ideal. So if you can get that history about the patient, are they taking any of those drugs? And have they taken them that day? Because when the patient arrives in the emergency department, it might be that we need to reverse those as quickly as possible. So I don't really have time to go into massive detail on the NICE head injury guidelines, but again, something for you to read up on. And this was published in May 2023. And if you go to the recommendations, it will tell you which patients should be taken to the emergency department, which patients require imaging. And there's a really nice flow chart as well that you can find in the tools that just goes through what are the factors that you should consider in whether or not a patient needs a CT scan. And you could use those exact phrases to decide whether or not you're going to take someone to the emergency department or whether you can safely discharge them from scene. So have a read of those. Clearing the C-spine, massive topic, not going to go into it in too much detail. But remembering again that means we have to have assessed for these things. So do they have focal neurological deficit? We've done our power and sensation. Do they have midline spinal tenderness? We've talked about that. Do they have an altered level of consciousness, in which case we can't clear the neck? Are they drunk, or do they have distracting injury? Again, we can't clear the neck. And then often in hospital, we're using the Canadian C-spine rule. So if you have a look at this, this is what we use to decide whether or not we need to image the patient's cervical spine, and that is most commonly imaging the cervical spine with CT. And the thoracic and lumbar spine in low velocity trauma, we use X-ray, or high velocity, we use CT. And then just thinking about treatment, again, you look, there's a bit of a theme there. It's basic management, maintaining ABC. Obviously, if we think someone's got a spinal cord injury, we do need to immobilise their spine, stop them from moving around, and get them to the right centre. And one of the things I've written there is mode of transfer, and that's to remind me to talk about this. So obviously, I work on an air ambulance, on a helicopter platform, and we do quite often get calls from crews who are keen to use the air ambulance to transfer a patient quickly to a major trauma centre because they think they've got a spinal injury. And one of the things that people don't realise is that when you're working in a helicopter, it's not a smooth ride at all. It's all over the place. That's why we all look a bit sick when we get out. But there's lots of G-forces involved. There's lots of abrupt movements when you're in the wind. There's lots of vibration. So actually, for a spinal cord injury or a spinal fracture patient, getting in the helicopter is not a smooth ride. And when you're thinking about transfer times, it takes a long time to take a handover, load the patient into the air ambulance, obviously get going, unload them the other end. So just think, it depends where you are. If you're millions of miles away, then of course it might be relevant. But often it's going to be just quicker for you to get going if the patient's well enough, and you'll get to hospital just as smoothly as us. Your driving's cool, you'll be fine. So I've just got a few cases. I'm aware of the time and we might want to do some questions, but have a think about how you'd manage this patient. So 17-year-old front seat passenger of a car, and you're just thinking maybe they weren't wearing a seatbelt because they are untrapped, they're slumped in the vehicle. Maintaining their own airway. You've done a quick primary survey and there's no obvious chest, abdo or pelvic injury, but you are aware that they could well have with that mechanism of injury. Obs are looking okay, apart from GCS, which is 8. Pupils are equal and reactive, and they've got a frontal head wound. So just have a quick think, what are your priorities for managing this patient? Well, my priorities would be to get him out of the car as quickly as possible, to obviously get him onto the back of the ambulance to do another proper full primary survey with full exposure, bearing in mind that there may be other injuries that I missed initially. This patient obviously has a potential for a significant traumatic brain injury with that Glasgow Coma scale. He may need critical care support, so may benefit from a pre-hospital emergency anaesthetic, but I don't want to delay on scene to wait for that. I want to get going to a major trauma centre according to my triage tool, and this patient would need tranexamic acid according to the CRASH 3 study. This is a cyclist who's come off at high speed. Loss of consciousness witnessed by bystanders. When you ask them, he was knocked out for a few minutes, definitely. He was wearing a helmet, which is damaged. He's walking around, and you record his GCS at 14 because he's confused, and he's very repetitive and sort of keeps saying what's happened and looks a bit bewildered. He's got no other injury on primary survey and normal observations. What would you do with this patient? So I would probably walk him to the ambulance and get him to lay down onto a scoop. I would immobilise his cervical spine because he's got quite a significant mechanism of injury, and we can't clear it because he's quite confused and repetitive. And if he tolerates that, then obviously that's the best thing for him. And this patient doesn't trigger on our triage tools. He can go to any of the emergency departments locally and obviously hand over to them, probably slow speed if he's GCS 14. And in the emergency department, we'd reassess the patient again and have a look. If he's improved completely, he has had loss of consciousness and he has had a dangerous mechanism of injury. So according to the NICE guidelines, he would receive a CT scan. And if he's immobilised, we'll do the neck as well while we're there. But most likely this patient is concussed. And the last case, 78-year-old male has fallen off a ladder and he's on apixaban and bisoprolol for AF. So straight away, I'm thinking that's a direct oral anticoagulant. He's at high risk for bleeding. He's got a wound and a large swelling on the back of his head, and there's blood all over the patio. So yes, he's had a head injury and he's on apixaban, but also he's got external hemorrhage. So I need to make sure that I control that bleeding and it doesn't ongoing bleed all the way to hospital. There's his obs. So he is hypotensive for a 78-year-old man, and maybe his pulse is normal because he's on bisoprolol. But also, what's the cause of his shock? Is it external blood loss? Is it internal blood loss? Or has he got a spinal cord injury? So I'm going to actually have a proper look at the arms and legs. He's GCS14 confused. His pupils are fine. But yes, there's something not right about this gentleman's arms and legs. So this patient, I'm quite worried about him. He could deteriorate. We need to move very quickly, package him with a spinal immobilization, control that bleeding on the back of his head, and get moving to hospital as quickly as possible. And he sounds to me like he needs a major trauma centre, even though he doesn't quite trigger everything else. He's got enough going there that he needs that. So that's all from me.